All right. Well, hello to you, our listeners, the manipulated and the manipulators. Welcome to the OMM Research Podcast. The OMM Research Podcast is produced by DO-Touch.NET, a practice-based research network that focuses on osteopathic manipulative medicine research. DO-Touch.NET is based out of the A.T. Still Research Institute located at A.T. Still University in Kirksville, Missouri. Please note that the views and opinions of the panelists in this podcast are personal to each panelist and do not reflect the views or opinions of the A.T. Still University. My name is Corey Lubring, and I am the practice-based research coordinator of DO-Touch.NET and the host of the OMM Research Podcast. Before we get started, we just would like to remind our listeners that this podcast recording has video recorded with it and can be viewed on the DO-Touch.NET YouTube channel. As always, we want to start this episode by introducing our panelists, and we'll start with Dr. Amendolara.
Hi, my name is Al Amendolara. I'm a PGY1 in neurology at St. Luke's in Pennsylvania, and I'm also an adjunct professor of clinical research at Nordic College of Osteopathic Medicine.
And thank you for being with us again this month, Dr. Amendolara. And then we also have Dr. Stacey.
Hello, my name is Dr. Stephen Kimball Stacey. I am a Director of Osteopathic Education for the La Crosse Mayo Family Medicine Residency Program and Associate Professor of Family Medicine at Mayo Clinic.
And thank you also for being with us again this month. We're going to hop right into the articles for this episode. We're going to be starting with the article brought to us by Dr. Stacey, which is looking at selective manual therapy techniques in chronic obstructive pulmonary disease.
That's right. The title of this article is Effect of Selective Manual Therapy Techniques in Chronic Obstructive Pulmonary Disease, a Randomized Control Trial. The authors are Mohammed et al. It was published November 19th, 2024 in the Journal of Taiba University Medical Sciences. Apologize to anybody in Cairo who is listening and listen to me butcher the name. I keep on doing that in this podcast, is picking these articles from exotic places and then not saying the names right. So the research question is, in patients with mild to moderate COPD, does the addition of manual therapy to physical therapy improve pulmonary outcomes compared to physical therapy alone? And from the abstract, their findings are the combination of manual therapy approaches with conventional physical therapy leads to a clinically significant difference in anterior posterior chest expansion, FVC, FEV1, CVA, which is the which we'll talk about more, functional capacity, and dyspnea, and a statistically significant difference in kyphosis angle, FEV1 to FVC, and lateral chest expansion compared to using conventional physical therapy alone in patients with COPD.
Wonderful. So apart from being something that's recent, what jumped out to you related to this article that you wanted to bring it to the podcast today?
They did a lot of things that I like in manual therapy trials that I want to highlight. Let's start with the rationale. They went into a detailed review on the kinds of findings that have previously been shown in the literature for patients who have COPD with um, regard to how might manual therapy make an improvement. So they talked about things like limited diaphragmatic mobility in patients who are kyphotic. Why might patients with COPD be more kyphotic? They talked about limitations in chest range of motion, and went into a little bit of detail on the kinds of therapies that they thought might make a difference there, and why they wanted to measure the things that they did. They reported on different studies that had looked at things like the FEV1, 6-minute walk test, health related quality of life, really setting up that there is background to this and we really are moving forward, and why this is what moves it forward. So I really like seeing that in manual therapy research. Contrast that with what you see a lot of times, which is sort of just picking something, it almost seems like out of thin air. You know what I mean, Al? Like you've
Yeah,
seen
at
that,
almost at random, to see if there's anything there, sort of, throwing pasta against the wall to see what sticks.
right? So in this case, the research was conducted by physical therapists, not osteopathic physicians. But I think there's a lot we can learn from the manual therapy approaches that they used. The setting was a hospital in Cairo, Egypt, from March 2023 to March 2024. So good on them for getting this into the journal by November. They write faster than I do, I think. So they call it a parallel double-blind RCT, which was powered to assess pulmonary function, but they didn't really specify the any more about the power in terms of what size of difference were they looking for. They just said that they would need to recruit at least 52, so 26 in each group. Um, so in terms of powering, I'm glad to see that they decided beforehand how many people they would need to recruit. The idea of powering, if you're not familiar with it, is to really say, how can we be sure that we got enough people to show something? So let's say that the study shows no difference whatsoever. Maybe that's because there's not actually a difference, or maybe that's because they just didn't get enough people to show a difference. And so when they're reporting powering, it's nice to say what is the size difference they were expecting to show so that you can interpret a negative study in that light. But that
Right.
they didn't do that here.
I
Yeah.
will say I think their effect size setting it at zero point 0.5 is actually a pretty, um, ambitious effect size. So I think they ended up finding significant results, so I suppose that was a reasonable goal, but I would have even accepted it at a slightly smaller effect size.
And
Um,
maybe you noticed this somewhere in the study that I didn't, but they just said generically pulmonary function, but they had a lot of
yeah,
pulmonary function outcomes like FVC, FEV1, the ratio. So I'm not sure
I'm
what
not
specific
100% sure what they were
thing.
going with either.
Um,
Um,
so
I
so that's a
appreciate that they
little
did
bit
it,
of a
but I
weakness.
agree. Yeah,
I'd say that's probably a weakness in reporting more than a weakness in design. But
Mm.
the thing about reporting weaknesses is they could potentially conceal design weaknesses, and you just don't
right,
really know.
right.
Um, so the subjects were they ended up analyzing 72 adults with COPT based on gold criteria diagnosed by experts in the field. They excluded patients. They reasonably excluded patients with certain major comorbidities like um, active cancer, uh, with
They did, like, heart
osteoporosis.
failure, yeah,
Yeah,
recent exacerbations, things like that, yeah. I
you
do
know.
wanna make a mention of the, inclusion. They limit it to patients from 50 to 60 years of age.
Mhm.
Um, I don't think that's totally unreasonable given the kind of usual age range that we're gonna see COPD in, but I do think it limits generalizability a little bit.
Yeah, it could, and also it makes it harder to recruit, so I don't know why you would
Yeah,
limit yourself in
eh
that way,
yeah,
but
to just 10 years essentially of
mhm. They did end up randomizing 26 to each group, so it seems to me like they probably stopped as soon as they met um, their recruitment goal. And all the patients received the intended intervention and were also included in the analysis. So, what was the intervention? Group A had physical therapy, and they described the techniques as pursed lip breathing, diaphragmatic breathing, active range of motion of both upper extremities. They did that 3 times a week for 8 weeks, so fairly intensive physical therapy, compared with the experimental group that got the same treatment as group one with also manual therapy. And they did a really good job describing the manual therapy techniques that they did. So they described the mobilization techniques, including joint oscillations with mobilization of rib, thoracic facet joints, costovertebral joints. They did this in seated, supine, prone positions and showed pictures of actual patients in the positions. They also did diaphragmatic myofascial release, as well as myofascial release of scalene neck pectoralis muscles, again, with pictures. So I really like including enough detail in a manual therapy study that you have a good chance of actually reproducing the techniques that were performed in the study.
Absolutely.
I'm
I
always
know,
a fan of pictures.
Always a
right?
fan of pictures. So,
No,
go
go
ahead.
ahead.
I just want to ask, so, not that I want to scare off any of our listeners by talking more about statistics and everything, but what really kind of jumped out about the results, the findings with this study, that make it something that can really be impactful upon OMM practice.
Yeah, so it's interesting. The way they set things up, it's they had a lot of different outcomes, and they didn't really differentiate between primary and secondary outcomes. So the difference really is the primary outcome is the thing your study is designed to find. So if you look at the power analysis, for
Mhm.
example, you can't do a power analysis for 50 different things and then just say, um, this is this is the easiest one to find, so we're going to do that. That looks a little bit like uh,
Like
uh,
cherry picking
cherry
or
picking.
Mhm.
yeah.
Yeah. Um, and you definitely shouldn't do that after the fact, which would be called post hoc data dredging, where you just go and you just sort of sift through things and whatever you can find. So you really target the recruitment and everything around finding a single outcome, but they had a variety of outcomes. So they were grouped around things like anthropometric measurements, so things like chest expansion, craniovertebral angle, kyphosis angle. They looked at things like pulmonary function, so FEV1, FVC, and then the ratio. And they also did symptomatic measurements like functional capacity, dyspnea level. And when you have a whole bunch of things like that, the more that you include, the greater is the chance that you're going to end up finding something that would be called statistically significant, even if there is no relationship between the variables. Right. So the example I use is, if you pour 20 M&Ms on a bag of M&Ms on the floor of 20 different colors, you're going to find one is statistically most significant to be closer to the wall.
Mhm.
Right. Um, but that doesn't mean that you've uncovered something inherent about the universe. So in this case, you want to say that the intervention really did make a difference on the pulmonary function, and they report that it did, right? So they showed that with each of these things, p-values are great, way less than one, like way less than one. But then again, you run into this problem of, well, how do we know that it didn't just do that randomly or by
Randomly,
chance?
yeah.
Mhm.
And that's where you get into the idea of correcting for multiple hypothesis testing. So they start with an analysis that just looks at all the variables and it says, okay, putting all the variables in one pot and all the other variables in another pot, like, are the two pots different at all, just from the get go? And so you can do that with a technique called ANOVA, or analysis of variance. And in this case, they did a multivariate analysis of variance, and we don't need to get into the difference, but that's kind of the gist of it, right? Is saying, like, are the two pots of soup different? And so you come up with the answer, yes, they're different, but it doesn't say necessarily which ingredients are different. And to
Mhm.
figure that out, you have to do what's
Well,
called a post
pairwise
hoc
comparisons.
pairwise
Yeah.
comparison. You want to explain that a little bit, Al?
Sure. So like you're saying, when you do an ANOVA, you put everything into a big pot or two separate pots for your two different groups, and you find out that your soup is different to keep that metaphor going. But you don't really know which ingredients are different, so you do pairwise comparisons, usually like a t-test or something, on each individual set of differences to find out which one is significantly statistically significant. Now, in their case, they have a bunch of different variables, and I think they rightly do a correction for multiple comparisons. So, as I touched on a little bit before, whenever you're running statistical tests over and over again, there's going to be a percent chance that you get incorrectly significant results just due to the fact that we set uh, our p-value somewhat arbitrarily at 5%. And so we'd always expect when you run enough tests to have a percentage of those tests come back as false positives. They chose to use something called a Bonferroni correction, which is a fairly conservative test, but reasonable here. It's kind of an older one.
And
Um,
so the issue with the Bonferroni correction really is gonna be that you are more likely to have a false negative,
yeah,
which
Mhm.
which
yeah, in
a lot of
practical
times
terms.
we put up with that because in research we've just decided we would rather have false negatives than false positives, and so a lot of things are geared towards that outcome frankly being more likely.
Mhm.
In this case, they found that the outcomes were positive anyway, so it's hard to really criticize their use of a
Yeah.
much more conservative correction.
Sure. So to kind of wrap up conversation on this article, what would be the message you would want our listeners to take home related to, this study, or where would you take this for like a next step?
Yeah, good question. So the what they found is that all of these things improved. But remember, the intervention was several times per week for several weeks, which is more often than we typically have the availability to do in osteopathic medicine. It was also protocol driven, which has its pluses and minuses. If we were to continue to evaluate this, I think looking at other types of manual therapy routines would be really important. Do you really need that intensive of a treatment to see the benefit that they showed? Could you do physician directed manual therapy as opposed to protocol directed manual therapy? And would the outcomes
Right.
be the same? And so I think they did a good job answering this question. I don't know that this necessarily needs to be repeated as it is. I think,
Well, I will say, I think their follow-up time, given how intensive this was and given the chronic nature of COPD, I'd be interested to know how people fare further out, whether this is something do we need to be doing continuous OMT for, years essentially as a chronic therapy,
that's
or does
true.
a one-off intensive treatment really make a difference that's since sustained over a period of time? I think those are the type of questions that this doesn't answer, along with,
Yeah.
variations in treatment protocol, whether physician directed therapy makes a difference or practitioner directed kind of
Mm.
treatment therapy makes a difference to
Mhm.
this.
You make a really good point that I would love to see a follow on report of what happened after 8 weeks, what happened at, you know,
6 months
5 months.
or a year.
Yeah.
Yeah.
Yeah. Awesome. Well, thanks for bringing that article to us this month. We just want to remind our listeners before we go into the next article that this episode can be viewed on the DO-Touch.NET YouTube channel. That's do-touch.net. And you can also check us out on the website if you want to see what's happening within the network. All right, so we're going to be jumping into our second article brought here by Dr. Amendolara, which is looking at visceral manipulation on constipation in obese adults.
Yeah, so this article is titled Osteopathic Visceral Manipulation on Functional Constipation in Obese Adults, a Randomized Controlled Trial. It was published in the Journal of Integrative and Complementary Medicine in, I believe it was 2025, by
2026.
2026, sorry,
Yeah, it
by
actually was
Zidin et
published
al.
April 9th,
Yeah,
2026. So
fairly
real
fairly
recent.
recently. By Zidane et al. I'm sure I'm butchering their name, as we'll keep this
Yeah,
theme going of
join the
mispronouncing
club.
everyone's names.
It's
um,
mispronouncing, I believe.
Mispronouncing, I like that.
so what they were looking at here essentially is whether or not visceral manipulation is effective at reducing the various symptoms of functional constipation, specifically in obese adults who had a BMI of over 30. They based the diagnosis of functional constipation on the Rome 4 criteria, which is a fairly common diagnostic set for this ailment. And they went and they did a visceral manipulation over 4 weeks. They had a pretty intensive treatment routine, and then they compared it to a sort of a standard of care, dietary recommendations, and some exercise and physical therapy recommendations. And then they took a look and they actually used a lot of the same approaches as our prior paper. They used a MANOVA, which is that multivariate analysis of variance. They did a Bonferroni correction for the pairwise analysis, very similar statistical tests here. And they found that their visceral manipulation group showed improvements in stool consistency, defecation, frequency, reduced pain, and lower laxative intake over their study period. And they conclude that this visceral manipulation that they used was an effective therapy in addition to the standard of care for this functional constipation in obese adults.
So apart from being hot off the presses, what is the hot take that you're wanting to share with us, bringing this article to us this month?
Well, constipation is a very, very common issue that we deal with, and functional constipation can be difficult to treat and to manage. It's common in obese adults, but in general, it's a very common issue, and it's generally defined as a constipation that doesn't have any sort of at least identifiable physiologic reason. So those reasons being medication use, like opioids can cause
Mm-hmm.
constipation, transit issues, meaning gut dysmotility or things of that nature, abdominal surgeries,
I
any
think one
sort of
thing I think one thing I'd contrast between this indication and the last one we talked about is we have in general a lot more options to treat constipation than we do to treat
yes.
COPD. And the constipation treatments work typically really pretty well. If you're going to compare that with other types of things where, their procedure was 20 sessions over 4 weeks, that's pretty intensive to treat constipation when we have probably a lot more patient-centered options out there.
I agree with that, but I think that at least in my personal experience, I know that dealing sometimes with these sort of chronic functional constipation patients, a low risk alternative option for treatments is nice to have. Sometimes people really just struggle with this for their entire lives, and we have things that work, laxatives work and things like that. But I think it's nice to
Yeah.
have an extra tool set, especially one or a tool in the tool set, especially one that is effective and doesn't have a lot of side effects or doesn't have a lot of other issues. I do agree, and I think there's an issue. There's the same kind of questions that this paper raises that yours did, which is this is a really intensive treatment. Their follow up is rather short, and this is a chronic long term condition. So, is this
Mm.
something that they would require long term continuous treatment for, or does this fairly intensive, shorter duration make a difference in 6 months or a year? and and
And
make a kind of a sustains.
correct me if I'm wrong. You read this in more detail than I did, but I didn't see anything that commented that actually the most severe patients were the ones selected for this study or people that had failed more conservative measures.
No, no, I didn't get any indication that this was anything that their inclusion criteria was anything other than um, patients who were diagnosed with functional constipation based
Mm-hmm.
on the Rome 4 criteria.
Yeah. And
Um,
so as people are interpreting this and trying to think about how would I use this in my own practice, I would just caution against saying I can do a single treatment, of visceral manipulation,
right.
and that's going to help with this constipation based off of the results of this study, because that's not what this study shows.
But this could be
Right.
like an additive something if someone was then being seen for something else and they had, a secondary complaint of constipation. If this shows efficacy, you could provide visceral treatment to treat it.
Yeah,
Yeah.
potentially.
Mm-hmm.
Yeah, I think so. I think the main strength of this is that it shows that there's something that could potentially work here.
Mm-hmm.
Um, Now they do have a fairly narrow age range. These were young participants, 18 to 25, who were obese based on BMI. So we have a fairly narrow study population. We have a short follow up, and again, we don't have a great sense of whether or not these participants had failed other treatments or had anything else going on. Um,
Let's be clear, that's not a failure of the study, right?
no,
It's
no,
totally
it's just a
okay that that's
consideration when we
yeah,
interpret these results.
absolutely.
And I think, you know, when we get into the statistical analysis and what they actually show, I think they generally did a good job. Um, they also do a power analysis. Their randomization seems reasonable. I think their outcomes are reasonable. I do think there's a question of how they divided their outcomes. One specific difference, I think, between our two papers is, and you can correct me if I'm wrong, but I believe they did essentially a single large MANOVA test
Yeah.
in your
Mhm.
paper. In this case, they split it between their primary and secondary outcomes, which, in my opinion, are somewhat arbitrarily chosen. They looked at stool consistency and pain for their primary outcomes, and then their secondary outcomes was defecation frequency and oral laxative use, which to me, I don't know why those were chosen as primary versus secondary outcomes. In my mind, constipation, especially functional constipation, the main thing I'm asking is how often are people going to the bathroom, essentially having
Mm.
bowel movements, in
Yeah.
addition to the pain or stool consistency. Um, so
Yeah.
I wonder if running multiple MANOVAs here with so few variables, I don't know if that was the ideal way to do this. I don't think it's wrong, but I think it's a discussion on the statistical decisions here.
Yeah, and some
There's
of them
also
too,
something, yeah,
just in terms of, selecting primary versus secondary outcomes, they do have some that are definitely patient-oriented outcomes like
yes,
suffocation pain, for sure.
yeah,
Some other ones I may look at as more of a, disease-oriented outcome, so like stool consistency. It's important to know
right,
about, constipation, but, if you ask people what's important about their constipation, they don't point to the Bristol chart, and they're like, "It looks like this and
right.
not like that." So that's more of a disease-oriented outcome, or it's something that has definitely good correlation with patient-oriented outcomes. So it's a good surrogate marker with evidence behind it. But I like to elevate the more patient-oriented outcomes to as the primary outcome, and I really try to design studies where there's just one primariest outcome,
I
and then the
agree.
rest
I
are
agree.
secondary.
I think they sort of split the difference a little bit too much here. They should have had either a single primary outcome or frankly, these could all be reasonably their sort of primary outcomes. I don't think they needed to make a real differentiation between them. In my opinion, I like the combination of more disease-oriented and patient-oriented outcomes. I think disease-oriented outcomes often give us more objective measures that sometimes get lost when we only focus on patient-oriented outcomes. So I don't think that they necessarily mischose their outcomes here, but I agree that I would have thought about it a little differently.
Yeah, I mean,
Uh,
I probably would have picked different ones, but I wouldn't say that that's the same as they made a mistake.
right, exactly. And
So
to be honest, I
we
feel
are
that
getting
way
close to
with
end
a
of
lot of
time. I do
their,
apologize. I
yeah.
just wanted to to kind of conclude the same way with the other one. What's the take home message you want our listeners to have for this, or where would you take the study for next steps?
Yeah, so I actually I think this is a well done study that shows a significant effect in their population, and I think it does a good job answering their question. In terms of how you would actually apply this, it's difficult for all the reasons that we sort of talked about. It's a limited patient population. It's a fairly intensive treatment, and we only look at limited follow up. So the recommendation from this would not necessarily be to run out and do an intensive 4 week osteopathic treatment on all your patients who come in with constipation. But I do think this gives us a reasonable basis to say that this works. It's a possible option for therapy if you're in the appropriate setting for it. And I also think that this gives us a good foundation to do further research, maybe broadening some of these things, maybe broadening our inclusion criteria,
Mm.
maybe looking at again further out follow up, maybe less intensive routines, things like that, so that we can put this into a more practical format that someone kind of boots on the ground could go ahead and implement into their day-to-day work.
Sure. Well, thank you both for joining us this month and for these awesome articles. Dr. Stacey, Dr. Amendolara, I want to extend my gratitude to both of you for being here again. To our
Hey,
listeners,
I was just gonna say, can we put in a plug for the upcoming conference?
oh yeah, no, absolutely, plug away.
Well, we've got the DO-Touch.NET annual conference coming up.
Yeah, so we have the DO-Touch.NET annual meeting coming up. That is going to be on June 13th. It's going to be all virtual. Starts at noon U.S. Central Time. If you would like to join us at that event, you can always register from our website, which is DO-Touch.NET. That's DO-TOUCH.NET. And you can also find out more of what's happening within the network from the website then. And then I believe, Dr. Stacey, you also have a conference coming up at the Mayo Clinic soon.
Yes, we have the Mayo Osteopathic Research and Education Conference on September 18th and 19th, 2026 in Rochester, Minnesota. It focuses on the practice, the research, and the education of osteopathic manipulation. If you want to come have a really high yield, fast paced, hands on conference, it's a great place to come. If you want to come discuss research like we're doing here, or present some research of your own, also great place to come.
And if you want to get in contact about any comments or if you have any questions about that, you can always reach out to me or us at DO-Touch.NET at atsu.edu. Or you can leave a comment on YouTube or your podcast platform of choice. And make sure you're also smashing that subscribe and follow button to continue to follow along with us. Thank you both again for being with us this month. That's going to conclude our episode.
Thanks.
Awesome. Thank you.